Welcome back to the deep dive. Today, we are looking at a condition that affects, over 16 million people in the US alone, dry eye disease, or DED.
Right, and when most people hear dry eye, they think, the solution is simple. My eyes just need more water.
And that's a good starting point, I guess, but it's not the whole story.
Not even close. If you stick with that idea, you miss the really dangerous chronic part of it, the fact that the quality of your tears starts to break down, becoming hyper-concentrated and, inflammatory.
Okay, so let's unpack that. We've got a whole stack of sources here. Clinical trials comparing treatments, deep dives on nutrition, and even some really fresh reports on investigational therapies and AI.
Our mission today is to move you beyond just thinking about moisture drops. We want to explore the whole multifaceted nature of DED, from the physics of your tears to the absolute cutting edge of what's in development.
And to start, we have to frame this correctly. It's a loss of homeostasis, a systemic imbalance, and it's really divided into two main and often overlapping types.
That's right, evaporative dry eye and aqueous deficient dry eye.
To really get that imbalance, though, we have to start with the tear film itself, because it is so much more than just water. Our sources describe it as this incredibly precise, complex structure.
Oh, it's tiny. We're talking about 2 to 5.5 micrometers thick. It's a fraction of a human hair.
And it's engineered in 3 distinct layers.
Exactly. It's a 3-layer miracle, really. The innermost one is the mucin layer. It's produced by goblet cells.
And think of that as the foundation, the glue.
The perfect analogy. It's the glue that anchors all the tears to the cornea, which is, funnily enough, naturally water-repelling. It's hydrophobic.
So the mucin preps the surface, then comes the bulk of the tear, the thickest layer.
Which is the aqueous layer. That's your water, your nutrients, proteins, all of that. It's made by the lacrimal glands and gives the tear its volume.
And then on the very outside, protecting everything.
That's the critical one, the lipid layer. It's an oil secreted by meibomian glands along your eyelid, and its whole purpose is to act as a barrier.
To stop that watery aqueous layer from just evaporating.
Precisely. And if you disrupt any one of those 3 components, you get DED.
Okay, so let's use those layers to classify it. First, aqueous deficient dry eye, or ADE. That's when those lacrimal glands just aren't producing enough of that middle watery layer.
Yeah, and that's often tied to bigger systemic issues. We see it with aging, of course, but also with autoimmune conditions where the body mistakenly attacks its own tear glands.
Like Sjogren's disease, lupus, that kind of thing.
Exactly. Rheumatoid arthritis, even thyroid disease can be linked.
But looking at the numbers, that's not the most common form, is it?
No, not at all. The big one is evaporative dry eye, EDE. It accounts for, some sources say up to 85% of all cases. Your eyes are producing tears, but they're just low quality.
Because that protective oil layer is failing.
Right, and that failure of the lipid layer is almost always caused by one thing, meibomian gland dysfunction, or MGD. The glands get blocked up or they atrophy, and the tears just evaporate way too fast.
What are the main risk factors for MGD that the sources point to?
Well, we see it a lot in patients with skin conditions like rosacea. Long-term contact lens use is a big one. And certain medications, most notably isotretinoin, which many people know as Accutane.
Okay, so this is where we hit the core concept, the thing that turns DED into this chronic illness, what our sources call the vicious cycle.
Yes, this is the key. You start with either too little water or that low-quality oil.
And then what happens?
The water evaporates too quickly, so the fluid that's left behind on your eye gets super concentrated. The technical term is hyperosmolar.
So it gets too salty? That sounds unpleasant, but what's it actually doing to the cells?
That hyperosmolarity acts like a powerful irritant. It's a trigger. It sets off this massive cascade of inflammation all over the ocular surface. It's like a low-grade chemical burn.
And that inflammation then damages the very glands that are supposed to be making good tears in the first place.
You've got it. The inflammation damages the goblet cells that make mucin, the lacrimal glands that make water, the meibomian glands that make oil. So the condition gets worse, which causes more inflammation, which causes more damage.
It becomes self-perpetuating.
Exactly. It locks you into a cycle that you can't break just by adding more moisture from a bottle. You have to deal with the inflammation.
That makes so much sense. Okay, moving into management. Let's start with the basics, the first line of defense.
Patient education and lifestyle, absolutely. Simple things. Avoiding high airflow, so, not sitting right under a fan. Using a humidifier. and being really conscious of screen time.
The screen time thing is huge. The sources said it can decrease your blinking rate by up to 60%.
60%. It's wild.
Yeah.
So when you're staring at your monitor, you're literally making your own dry eye worse by not blinking enough to recoat the surface.
It's also a big deal in surgery, right? Refractive and cataract surgery?
Oh, it's arguably the biggest issue facing refractive surgeons today. And it transiently affects pretty much all ASIC patients.
Why is that?
It's because of something called corneal denervation. When the surgeon cuts the flap for ALSIC, they temporarily sever the nerves in the cornea.
And those nerves are what sense dryness and tell your glands to make tears.
Precisely. You cut that communication line, and tear production just tanks for a while. Plus, the suction they use can damage the fragile goblet cells, so getting the surface stable before surgery is critical.
Okay, so once you've optimized lifestyle, you move to interventions. We looked at a really interesting clinical study comparing 3 options: punctal plugs, the drug cyclosporine, and then both together. Let's start with the plugs.
Sure, punctal plugs are these tiny devices they insert into your tear ducts to basically stop your tears from draining away.
So you keep more of what you have.
Right, and the study showed that plugs produced the most rapid improvements in wetness. People felt better, faster, and used fewer artificial tears right away. They're great for increasing volume.
But wait, if we just established that the vicious cycle means the tears are hyperosmolar and full of inflammatory stuff, aren't you just trapping those toxic tears on the eye?
That is the absolute critical insight, yes. While plugs help with comfort immediately, you could be marinating the eye in its own inflammatory chemistry.
So what did the study find long-term?
It found that only the cyclosporine-containing regimens significantly improved ocular surface staining over time.
And staining is the medical sign of actual cell damage.
Exactly. So plugs help with the symptom of dryness quickly, but the cyclosporine was what promoted actual long-term healing by targeting the underlying immune response.
It's an immunomodulator, right? It calms down the inflammation.
Yes, it tells those inflammatory cells to stand down. And the study found that the combination therapy plugs for volume plus cyclosporine for the inflammation was superior overall. It's treating the symptom and the cause at the same time.
That makes perfect sense. Okay, so if inflammation is the engine here, let's talk about the fuel we're putting in our bodies: nutrition.
It should be a top priority, honestly. And start simple.
Yeah.
Hydration. At least 64 ounces of water a day. And we even saw mentions of antioxidants in things like green tea catechins, which can help with hydration and oxidative stress.
But the real star of the show for eye health is omega fatty acids.
Oh, without a doubt. Omega-3s are crucial. Their anti-inflammatory properties get activated right there in the tear film. And a deficiency is a known root cause of this kind of chronic inflammation. We're talking a therapeutic dose, maybe around 2,000 milligrams a day.
For someone looking at a supplement bottle, what should they be looking for?
You want to see high concentrations of EPA and DHA, making up maybe 60 to 85% of the formula. And this is important to look for triglyceride forms. They have much better bioavailability than the cheaper ethyl esters. Your body can actually use them.
And there was another lesser-known omega that's key for eyes specifically.
Yes, gamma-linolenic acid, or GLA. While EPA and DHA are great general anti-inflammatories, GLA seems to target inflammatory markers that are particularly active on the ocular surface.
Where can you find these?
Food sources are great: wild salmon, tuna, walnuts, and then you have flax, chia, and hemp seeds, which are packed with them.
Beyond the omegas, the sources highlighted 4 key vitamins. Let's start with vitamin A, or beta-carotene.
Vitamin A deficiency can cause severe dry eyes on its own. It's vital for cell turnover, especially for the corneal epithelial cells. One study showed it reduced the number of dying cells tenfold.
And you find that in things like carrots, sweet potatoes, spinach, kale.
All the classics. Then you have your big antioxidants, vitamin C and EZ. Helps with healing and forming collagen in the cornea. E is great at neutralizing oxidation and protecting cells.
And finally, the sunshine vitamin, vitamin Z.
A vitamin D deficiency is directly linked to impaired tear film function. It helps decrease inflammation and improve tear secretions. There's a really clear link between, your lifestyle and the physical health of your eyes.
So to make this really actionable for you listening, our sources gave a dry eye smoothie recipe. Spinach for vitamin A, berries for C, flax or chia for omegas, almond butter for E. It's like a targeted anti-inflammatory meal for your eyes.
And optimizing that diet is so important because it lowers the whole inflammatory burden on your body, which lets all the other therapies work that much better.
That brings us to the cutting edge. Now, diagnosis is famously tricky with DED, right? The signs a doctor sees don't always match the symptoms a patient feels.
Exactly. It's a huge problem. You can have a terrible-looking cornea but feel fine, or feel awful but your eyes look okay. This is why the field is moving toward metabolomics.
Which is what exactly?
It's analyzing the complete metabolic profile of your tears, basically looking at all the tiny chemical byproducts of gene function to get an objective fingerprint of what's going on.
And we saw a study that used machine learning, AI, to do this with cataract patients.
They did. And the AI showed that just by analyzing the specific chemistry of the tears, it could accurately classify who had dry eye and who didn't. The logistic regression model was particularly good. It achieved an AUC of 0.8378.
For those of us not in data science, what does that number mean?
It means it's a very strong and reliable test. An AUC of 1.0 would be perfect prediction, so 0.8378 is excellent performance. It shows we can move toward a truly objective diagnosis.
Let's shift to treatments in the pipeline. These are targeting totally new mechanisms. First up, something to physically unblock the meibomian glands.
Right, this is a keratolytic. The drug is AZR-MD001, and it uses selenium sulfide to directly soften and dissolve the hardened keratin plugs that block those oil glands. It's a mechanical approach.
Then we have this really fascinating nerve targeting approach, TRPM8 agonists.
This is elegant biology. The TRPM8 channel is basically the cold and menthol receptor on your corneal nerve endings. When your tears evaporate, the surface cools slightly. That cooling activates TRPM8.
Which then sends a signal. Where?
It triggers the trigeminal nerve, which then tells both the lacrimal gland to make more water and the meibomian glands to release more oil. It's the body's natural feedback loop for tear production.
So a drug like AR-15512 is basically just flipping that switch on purpose.
You got it. It's tricking the eye into activating its own reflex, and the trial data showed it worked fast. A significant 10-millimeter increase on the Schirmer tear test by day 14.
Beyond that, there are a few drugs tackling inflammation and repair.
Yeah, a few different angles. You have Reproxalap, which rapidly reduces inflammation by targeting harmful chemicals called reactive aldehyde species. It hit its primary goal of reducing discomfort in a phase 3 trial.
And PL9643.
That's a melanocortin receptor agonist. It uses a known anti-inflammatory pathway to give rapid pain relief, sometimes in as little as 2 weeks.
What about actually repairing the physical damage?
That's the idea behind ST100. It's a collagen mimetic peptide. It acts like a scaffold to help repair the damaged corneal collagen and extracellular matrix that DED causes, which helps restore the nerve bed underneath.
And finally, for the most severe cases, there's a regenerative approach.
Yes, RGN-2529, which is thymosin beta-4. It's a regenerative protein used for things like neurotrophic keratopathy, where the cornea is severely damaged. It helps epithelial cells migrate and heal. One study saw complete healing in 60% of treated eyes.
60% versus just 12.5% in the placebo group. That's a huge difference.
It's a game changer for those severe cases.
Yeah.
It's essentially helping the eye rebuild itself.
So after this whole deep dive, what's the big takeaway for you listening right now?
It's that DED management has to be multimodal. You need the foundation, that diet, hydration, lifestyle. Then you layer on conventional treatments, maybe plugs for volume, but definitely something like cyclosporine to handle the chronic inflammation.
You have to treat the inflammation.
You have to.
Yeah.
And the future is moving away from just guessing. We're heading toward precise diagnostics using metabolomics to see your exact chemical imbalance.
Which then allows for these mechanism-specific drugs, hitting the glands with a keratolytic, the nerves with a TRPM8 agonist, or the surface with a regenerative peptide. It's personalized medicine for your eyes.
And it promises both that rapid relief people need and the long-term structural repair to actually break the cycle.
Which brings us to our final thought for you to take away. If machine learning models can accurately identify a complex chronic condition like dry eye just from the subtle metabolic shifts in your tear film, what other chronic conditions might we be able to detect or understand better simply by analyzing the dynamic chemical output of our own bodies? Thanks for joining us for the deep dive.